Okay, so welcome to the advanced strategies section of the TRT Masterclass. As I mentioned in the free YouTube video, if you've checked that out already, this is the exclusive content for the TRT Academy. The reason why I wanted to make this additional content, this is primarily focused for practitioners as well as enthusiasts or people who are troubleshooting their own cases. I do mention in the YouTube video that you must work with an expert provider, but I also do recognize the reality that many of you are not able to do that for geographical or financial reasons. So I am still going to be providing you with the education that you need, but this is really focusing on the higher level stuff for providers. It's the higher level of the basics. So when it comes to fixing protocols, one of the challenges that I've had in my career doing this is working with men who've been, for a lack of a better term, fucked by their previous provider. Unfucking these men is a process which is not always straightforward and is very unique case by case. And there are some recommendations that I've put into place here, which I think is a great place to start with these situations before looking at narrowing down your focus into what specifically needs to be done person for person. So, number one is remove all unnecessary supplements and medications. Guys will often come to me on a laundry list of things that they've heard about on podcasts, they've bought on iHerb or Amazon, or research chemical peptides and repurposed medications for longevity that they don't even know about in doses that they've bought online. I have seen all kinds of things. So the first thing I do is we eliminate everything that is not necessary. So if someone's been on a medication for life and they need to be on it, we're not eliminating that. Obviously, we're not eliminating their hormone replacement therapy, but if they're taking pregnenolone, DHEA, because they read about it online and they haven't checked for it, and they're taking, all kinds of stuff, whatever, pre-workout supplements, peptides, whatever, we drop everything unnecessary. That's number one. A lot of the time, it's not that we need to add things in, it's we need to take things out. The next thing that I will always recommend that you do, and I have this included in my preliminary testing for both of my clinics, is checking for Hashimoto's antibodies. I have been very surprised in the last year working with much higher volumes of clients through clinics, how often subclinical hypothyroidism shows up, and it's only really detectable when we look for the Hashimoto's antibodies. Hashimoto's antibodies, if they're elevated but still within the range, can cause subclinical hypothyroid symptoms. And it's extremely important to understand that the body will not tolerate the optimal testosterone level with subclinical hypothyroidism. The body needs optimal thyroid for optimal testosterone. One would never naturally occur without the other, so it's very important that we're testing and optimizing thyroid if it requires some support. I also recommend removing HCG. HCG is the ultimate curveball in this. I have seen it cause side effects in just as many men as I've seen it cause benefit. I think that the subjective benefits are not worth the unknown of the long-term risks, as well as overcomplicating the protocol. And I have discussed this very extensively in the Beyond TRT lecture, which you can also access from this group. Removing HCG, especially if they've been on it from day one, great place to start. And a lot of the time, if someone comes in with no thyroid lab testing, they're on HCG and a bunch of other supplements, it's a very easy fix because we can just do all of these things together and see where they're at. The other part that's important to recognize is a lot of men will be put on psychiatric medications for their hypogonadal symptoms before they understood to look into the hypogonadism that's causing the problems. This is really sad. And it's really difficult when these guys have been on these medications for 5 years, 10 years, 20 years. In situations where they need to remain in place, or at least they need to remain in place for a period before the client or patient decides that they want to wean off them, they often need to understand that they won't get the full benefits of testosterone replacement, especially if they're on high doses of SSRIs or if they're on antipsychotic medications. So if someone is obese and they have an elevated HbA1c, while I always like using a transcrotal cream in this instance, I also find that metformin at 500 milligrams to 1,000 milligrams in an extended release version twice per day is a great way to modulate the insulin-resistant processes in the body to prevent the side effects from TRT. When metformin temporarily alleviates the insulin-resistant state, this allows the testosterone to metabolize properly in the body. When men come in with elevated HbA1c, I strongly recommend looking at metformin if they're not already on it to be able to optimize HbA1c in conjunction with testosterone, which should also support bringing that HbA1c down a little bit, and then combining that with a transcrotal cream protocol and proper diet and lifestyle, doing that together as opposed to just putting these men on testosterone injections is a game changer. But it has to be done with the diet and lifestyle change as well. I also strongly advise that you all check every hormone. Pregnenolone, DHEA, and thyroid especially. You must look at these. And if you want to practice hormone replacement therapy, you can't just be looking at testosterone. This is like being a mechanic and only knowing how to service a small part of the engine. You can't just service one part of the car and expect to fix everyone's problems. So pregnenolone, DHEA, and thyroid are extremely important to be able to understand and identify deficiencies for. And if you don't treat these yourself, you need to refer out to someone who can. If someone has a deficiency in pregnenolone, DHEA, and or thyroid, they're not going to ever optimize their health and well-being with testosterone alone, and the testosterone is always going to give them side effects regardless of the dose or administration frequency. So it is extremely important that you learn how these hormones work. And fortunately, if you're in this group, you're in the right place. The Beyond TRT ebook and the lecture is a great place to start. The Pregnenolone Masterclass is already up, and the DHEA and thyroid masterclasses will be coming very soon. But there is so much information already in Beyond TRT that you should be able to have a great start for this. Coming back to this topic of the transcrotal cream, I really strongly recommend having this in your toolbox for men who have high levels of systemic inflammation. When men have upregulated production of prolactin due to chronic pain and stress, they are not going to metabolize testosterone properly into DHT. When men have upregulated levels of aromatase from excess body fat and they are insulin resistant, they are not going to metabolize testosterone and respond properly. And using things like aromatase inhibitors is not the solution for this. Taking 800 milligrams of ibuprofen a day is not a solution for this. So while it is extremely important to teach these men the importance of actually fixing their problems and ideally being able to refer to practitioners and providers who can assist with that, is transcrotal cream allows us to bypass some of these inflammatory pathways and allow the testosterone metabolism to reflect that more of what a healthy man would be. This has been a game changer because this subset of men are very difficult to treat because they are very sensitive to side effects. And having a solution which also doesn't involve doing injections is a really nice way to be able to initiate men on TRT in a side effect free fashion that otherwise wouldn't be able to be done. I have been blown away by the amount of men who I've looked at and been like, they are going to come back with problems with this because they're not looking after themselves properly. And they come back at 12 weeks and the only side effect that they're complaining about is they have to shave their balls. It's incredible how well the cream works for men who are inflamed and who are insulin resistant. Any man who has liver issues, the cream works very well with because the ester doesn't have to be cleaved in the liver as well. And disruptions in the body's ability to cleave the ester means disruptions in the body's ability to maintain stable hormone levels over time. Cream protocols can be weighted more towards AM delivery if the PM dose impacts sleep and it's not able to be resolved by melatonin supplementation. Androgens antagonize the melatonin receptor, so using melatonin will often solve this problem. However, some men will find that while cream will help a good subset of men sleep better, the evening dose of cream seems to reduce their stress. In other men, they'll find it stimulatory. So while I don't think once daily dosing for cream is optimal, it can be done for some men if that's only what's going to work for them. But I think you can also weight the cream more heavily in the morning, such as doing 3 clicks in the morning, 1 click at night, to at least make sure that there is still symptom resolution and they're not becoming hypergonadal in the early hours of the morning. Daily injections are also going to be a part of a TRT practitioner's toolbox. This is because not every man will respond properly to cream, and not every man will have cream available to them. So if someone is in a situation where they would benefit from transcrotal cream, but it's not available or they don't absorb it properly, then daily injections will solve this issue. Most men do not like doing daily injections, but what I like to explain to my clients is that it's a short-term treatment until they get their health on track. So if they don't want to do daily injections anymore, they need to do daily injections. And the way that they don't need to do daily injections is reducing their body fat, stop drinking alcohol, improve their overall body composition, and improve the quality of their diet. When they do that long term and their body starts to heal and become less inflamed, they can then move down to a 3 injection per week. As I said in the free version of the video, subcutaneous injections don't always work. They are going to be much more preferred to daily injections, but some men will need to do IM daily shots for 6 months, and they can suck it up because they got themselves into the poor health situation that they are in, and they need to get themselves out of it. Tadalafil is also a very interesting medication to use. I often recommend it for men who are experiencing erectile dysfunction, and the erectile dysfunction is putting stress on their relationship, because a daily 5 milligram tadalafil tablet will allow them to restore spontaneous intimacy and natural occurring erections. Some men will need 10 to 20 milligrams of this per day, depending on their weight and degree of erectile dysfunction. But it's also important to note that tadalafil does have some mild anti-inflammatory properties, and men who fall into this category of having these startup estrogenic side effects can often really benefit from about 3 to 6 months of 5 milligrams of tadalafil when they begin their treatment. The last additional point that I want to bring up in this expansion module is that men under 30 are a completely different kettle of fish to treat than men over the age of 40 and 50. One, men under 25 are very difficult to get to follow direction. That's a maturity issue. But men under 30 can often be severely symptomatic with free testosterone levels that would be borderline problematic for others. I routinely see men in their mid-20s with a free testosterone level of about 375 to 425 picomole per liter, and I'll throw up the picogram per mil units here for people in the US. And I find that it's very difficult for these younger men to get treatment because on paper their levels don't look that bad. It's important to note that men, when they are younger, are supposed to have very high testosterone levels when they're healthy. So for a young man to have his free testosterone level at a 400 picomole per liter, this could be just as bad biologically or just as unnatural biologically as a 50 or 60-year-old man having his free testosterone at 200 picomole per liter. So it's important that we understand that younger men will often become symptomatic at higher levels. And what is not understood from this in many practitioners, they'll understand the first part, but what they won't recognize then is that if he is hypergonadal at a level that most people would be okay at, that means that he's likely going to need to push his treatment up a lot higher to achieve the symptom resolution that we need. If someone is hypergonadal at a free testosterone of 100 picomole per liter and they feel great at 500 picomole per liter, that makes sense, or 600 picomole per liter. But if someone is severely hypergonadal at 400 picomole per liter, it is not reasonable to assume that if we increase their dose by 50%, that we're going to get the same response as if we'd increase their levels by 400% as we did in the former. So it's very common for these younger men to need their free testosterone level, and again, I'll post the conversion up here, closer to 1500 picomole per liter to achieve symptom resolution. But again, I recommend working up to that level gradually to give their body time to adjust. So I recommend 3 times weekly injections at a minimum when you're working with these younger men. These younger men also seem to be more prone to the peaks and troughs, maybe due to the history of endocrine disruption. I am not really sure why this is, but in practice, if a man is under 30, I recommend 3 injections per week until he stabilizes after a period of 2 to 3 years, in which case you might then want to try doing 2 injections a week to make the protocol more sustainable. Again, younger men will also tend to benefit from the increased conversion to DHT from transcrotal cream. I do believe that this is due to more exposure to endocrine disruption and xenoestrogenic compounds in youth. It makes sense to me that younger men do better with more androgenic metabolism of their testosterone to make up for the xenoestrogenic and the proverbial pool of estrogen that they have swum in their entire life to be compensated for by better DHT metabolism. As I said, daily tadalafil can be great to help with restoring sexual confidence for 6 months, and I generally find that if you prescribe it daily for patients or clients, they will stop taking it or forget to take it when it is no longer needed. Increased blood pressure must also be resolved, and this is a really important point to look at, and this is actually the final point that we're going to look at today. One thing that is very common when men start TRT is they will develop hypertension. And the reason why they developed hypertension is that they had subclinical hypertension to begin with, and testosterone replacement therapy pushes them into full-blown clinical hypertension. This increased blood pressure state is extremely stressful for the heart, and it is not healthy for any biological function. What this is highlighting is a lack of cardiovascular fitness. And it's very common for low testosterone men to not do much cardiovascular exercise because it's very stressful and it feels uncomfortable. The body's not able to produce the proper endorphins and the runner's high in response to training, so people don't do it. When someone goes on testosterone replacement therapy and optimizes their testosterone level, it means, as I said before, they need to create the environment where they would be making those levels naturally if they could. When you bypass these rate limiting pathways, it's very important that you go back and tick them off. Otherwise, the fact that you have bypassed the body's natural bottlenecks can come back and bite you in the ass. So, if you want to have optimal testosterone levels, you have to have optimal cardiovascular fitness. And the way that you get optimal cardiovascular fitness is training cardio regularly. Many men don't want to do this, or they only view cardiovascular training as a means to manipulate calories out. This is a mistake. If you are passionate about improving and optimizing your testosterone levels, to be able to tolerate the testosterone levels that you want and to achieve the outcome that you want, you need to do more cardio to improve your cardiovascular fitness. I recommend working with, as I said, my friend Ellie Gilbert up here. You can also work with the people who train me, Muscle Nerds. Otherwise, you can work with your local personal trainer on it. But work to improve your cardiovascular fitness, both by getting in plenty of steps per day, 10 to 15,000 steps a day is fantastic, as well as training dedicated cardiovascular exercise. I think medications like telmisartan, which is an angiotensin receptor 2 blocker, can be utilized for a short-term period while someone is correcting this. But these medications should not be looked at as a long-term solution. The long-term solution is improving the body's cardiovascular function via training cardiovascular exercise. The supplements omega-3 in a combined dose of 3 to 4 grams of EPA DHA per day, as well as 100 to 200 milligrams of ubiquinol, can also be very helpful for this in the interim while the individual is working on not needing this external support anymore. So that is everything. Thank you for watching, and I will see you on the next one.